Welcome back, everyone, and happy National Infertility Awareness Week. It's good to be with you 2 nights in a row. And I have breaking news. Officially, my book is live on Amazon, so head on over to get your copy now. So joining me this evening is Dr. Enrique Soto of IVFMD, and our topic for discussion this evening is fibroids, PCOS, and more.
Hello.
Hi, Dr. Soto. How are
Hi.
you?
Good, good. How are you doing? Hi.
I'm doing great. I'm happy to have you. I've been meaning to have you on for some time, so this has come full circle. So welcome. How are
Thank
you
you.
this evening?
Very good. Excellent. Thank you.
Great.
Coming back from a day at the office, but I'm always happy to talk more about fertility. And thank you so much for the invitation. Yeah.
My pleasure, and thank you for your willingness. So I'd love to start off with just getting our audience familiar with you.
Sure.
And you provide such an amazing service for women and their families. Can you tell me what drew you to IVFMD in particular?
Sure. When I finished my training, my wife and I were looking for a place to live, and we're actually not originally from Miami, but we were looking for places, and then Miami came to mind, and then I actually came and I met with Jürgen Iserman, my partner now, and the team, and I was actually very impressed with their team, and they've been in practice for quite a few years before I joined them, and it was kind of like a perfect match for us and professionally, and I've just been very happy from day one. Yeah.
Good for you. And it looks like a solid team across the board. Can you tell us a little bit of your educational background, just so that our audience can get to know you a little
Yeah.
bit more?
Yeah, sure. I trained in Mount Sinai, New York. I did my OBGYN training there, and then I have like a subspecialty on actually minimally invasive surgery over there in Mount Sinai, New York. And then I did a master's in embryology, and then I finished in Cleveland Clinic doing REI, reproductive endocrinology and fertility. So it was New York, and then Cleveland, and then finally Miami, as a final destination.
Wonderful. So let's dive into it. Let's just find out a little bit more about fibroids and what causes them.
Sure. So fibroids are very common, and the thought is that it's a multifactorial medical problem. So there's a very important genetic predisposition. We know that it's more common in certain backgrounds, etc. And it tends to run in families as well. And the thought is that the fibroids, which are benign tumors of the uterus, there's this areas of the uterus. The thought is that they're more, in a way, more prone to the changes in the hormonal environment, and then they start as a single cell that actually starts dividing, kind of like a tumor, and then it starts growing, and in a way, it's also like the disease can present itself different. Some women have one very large fibroid that we treat, or we do surgery for it, and then it doesn't come back, or they don't get any more new ones. And in some other women, it tends to be more a recurrence of the fibroids with multiple. So in a way, it can present clinically very differently from one woman to another.
Good to know. So what are some of the symptoms?
Sure. So they can be completely asymptomatic. So some women wouldn't know that they have them. And then commonly they can cause heavy bleeding, heavy menstrual bleeding, or bleeding in the middle, in between one period and the other. Intermenstrual bleeding, we call it. Postcoital bleeding, which is after having sex, having bleeding. When the fibroids are very large, they can also cause some bulk symptoms. So it could be some pelvic pressure, pain during sex, painful periods, or also while urinating or going to the bathroom, there can be some discomfort. This is when the fibroids are large. And then in other patients, it presents itself with fertility issues, infertility.
So, how are fibroids diagnosed?
So normally they can be diagnosed with physical exam, but the more common way to diagnose them is with a regular ultrasound, which can be done in some cases abdominal, which is from the top, or transvaginal more commonly. And this is a very, very accurate way of knowing exactly the location of the fibroids, the size of the fibroids. There's other ways. Sometimes we order an MRI, but more commonly but with a regular physical exam and an ultrasound, it's enough to diagnose them.
What do you recommend for patients as they undergo any fibroid surgery removal?
I think the key part is that while they need to certainly go see a specialist, some of the surgeries require removal hysteroscopically, which is a procedure that's done through the cervix through a little small camera, and fibroids that are located on the inside of the uterus where the pregnancy grows. Those surgeries are typically done by either OBGYNs or fertility specialists. And then larger fibroids need to be removed actually abdominally, so from the top. So either through small incisions, laparoscopic or robotic. And in cases where they're very large, they may need like an open surgery, similar to when someone has a C-section. So I think the key part is to know, which kind of fibroids the patient has, the size, the location, and then pick the right physician and surgeon to treat them. Some of them can be very well performed by the OBGYN team, and others is more either a fertility specialist or a GYN oncologist in certain cases. For example, when they're very, very large, it's not rare that a GYN oncologist would do the surgery. Not that it's cancer, but just because of the skill that they have.
So, what can patients do to help their fibroid symptoms? How can they be proactive?
I think that there's some medical therapy for fibroids that's more new, and it's still in some ways experimental. But in most cases, fibroids can either be monitored and then when an intervention needs to be performed, it's surgery. So I think the key part is to know, keep track of the symptoms. It's not that all patients need to have ultrasounds, to rule them out. No, but when someone has a symptom and there's a fibroid, I think we have to monitor that symptom. So, if the patient doesn't want to get pregnant, they have a fibroid that's maybe 2 centimeters, then, if there's more bleeding or there's other symptoms, then definitely you should follow up with an expert.
Mm-hmm. One question that got sent in was, can this cause a drop in ovarian reserve in AMH?
No, fibroids are not associated with that. Now, for the most part, surgery for the fibroids should not affect the ovarian reserve either. Very specific cases where during the surgery something else needs to be done regarding the ovaries, it might. But the ovarian reserve refers to how many eggs a patient has, and then so that's in the ovaries. And fibroids are located in the uterus, so fortunately it's in different places.
Mm. Our other topic for discussion tonight is PCOS. We get a lot of questions about PCOS. For those who don't know, let's just take a step back and give us a little bit.
Yeah, of course. So polycystic ovarian syndrome is a very, very common condition. Maybe approximately 6 to 10% of women actually have it, and is one of the more common causes of infertility. There's different types of PCOS, but generally speaking, women would have irregular periods because one of the primary components is an ovulatory problem. Ovulation is when women release an egg when they ovulate. So someone that has a very regular period once a month, very likely they're ovulating. So women that have an ovulatory problem, instead of having periods every month, they might have a period every 2 to 3 months, for example. So it tends to be an ovulatory issue. And then other women have problems with an increase of the testosterone or the androgens, which is thought more to be the male hormone, but women produce testosterone as well. So when that hormone goes up, It could be associated with issues like having, some extra hair, for example, and so you have the component of the ovulatory problem, the elevated androgens, which can be clinical, or it's something that we can check with a blood test. And then when we do an ultrasound at the office visit, one of the cardinal kind of signs is that the ovaries have this very specific appearance. So normally when we do an ultrasound and someone does not have PCOS, maybe you can count about 5 or 6 follicles at any given time. When someone has PCOS, it tends to be an ovary that has many, many, many little follicles, often arranged in the periphery of the ovary. And that's we call that the classical, PCOS appearance of the ovary. And some patients also may have maybe overweight or obese, but not all. There are women that you can even be, underweight and have PCOS. So at our office, we typically see them for any of these reasons, right? A little extra hair maybe, or elevated androgen symptoms, or we see them because they have very irregular periods and they haven't been able to get pregnant. So those are probably the 2 more common reasons that they come see us at the office.
Good to know. So what are some of the strategies you do to work with patients who have PCOS and help them reduce the symptoms?
Yes, sure. So it depends on what the overall goal is. So if a patient has PCOS, irregular periods, and they do not wish to have kids anytime soon, then often the treatment would be to do birth control pills, which is just oral birth control pills, because giving them those hormones actually regulates the cycle. It's not helping with the ovulation, but it can prevent a lot of the issues that come with not having periods. So when someone has a severe form of PCOS, for example, some women do not ovulate at all. So we can sometimes see patients that say, well, I had a period 2 years ago, I haven't had one since, and they have PCOS. And not having a period in those cases actually means that they've been on elevated estrogen levels for a prolonged time, and that can lead into issues of the endometrium, the inside of the uterus, things like precancer. So in order to prevent all of this, we often would recommend going on a birth control pill. And conversely, when someone wants to get pregnant, then our patients will need often help with the ovulatory part. So we do our workup, and then they'll need specific medication to help them ovulate.
What is the best PCOS diet?
So there's no specific diets that have been associated with to help PCOS, but there's some research performed on generally for fertility what would be one of the best diets. And this is not a diet to lose weight, but it's just a way of eating, right? Our diet. And something similar to the Mediterranean diet is what we recommend, and there's some research to back that up. So in a Mediterranean diet would be, high on grains, protein, fish, olive oil, nuts, very, very, very few or very little red meat, and certainly also make sure that we don't eat excessive carbs. So if someone went ahead and Googled, Mediterranean diet, they can get an idea of what things would make sense to do that. Now, if someone if someone's overweight or obese, and have PCOS, and actually the number one recommendation or the first recommendation is to work on that as well. So often we'll have to refer them to a dietitian or a nutrition specialist to help us with that.
Hi, everyone. So we had some technical difficulties. We left off basically on you started to talk about the best PCOS diet, Mediterranean.
So it's there's no specific diet for it, but generally there's some research on the Mediterranean diet for fertility that has shown to be beneficial. So I always recommend my patients to try to research that. Now, if someone is overweight and has PCOS, actually the first line of treatment is actually to lose weight, exercise, eat healthy. So we often will send our patients to a nutritionist, same as Martha at our office, and an expert on it, because working on weight loss in these cases is the paramount.
How can someone thrive with PCOS?
I think the key part is to know exactly once you have the diagnosis, is having a very clear path of what the goal is. If the goal is to control the symptoms, prevent issues, then we take typically the hormonal route, birth control, and on the other hand, if we're going more on the fertility route, then I would recommend going straight to a fertility specialist, because typically with PCOS, something like in the lines of Clomid or Letrozole, which are medications that to help ovulation, will be needed, and often monitoring is recommended in these cases. So that's why whenever a PCOS diagnosis has been made, the best person to see is a fertility specialist.
Absolutely. So do you recommend any supplements for clients?
So typically, no. There is some research that inositol might help also with PCOS. So that's one of the supplements that we can talk about trying. But certainly I would say that the supplements is something that's in a way tertiary. I think more diet, exercise, and taking the proper treatment path is definitely the way to go. And the supplement, something like inositol, is also used specifically when we're going more the fertility route.
Got it. So switching gears, I like to ask all my guests, Dr. Soto, what you like to do to de-stress. You're a busy person.
Yes. So well, I'm actually I love music. So I play guitar and
Wow,
learning some
multi-talent.
piano on my own. Sing a little, and so music.
Nice.
I think it's is probably the what I like to do, and just spending time with my family, my wife, and I have a 2.5-year-old. So that actually with our daughter, there's very little time for music.
Oh, sure. I can imagine, but
Yeah.
good for you for taking some time out for your hobbies. Now, let's just address one question.
Sure.
I already made an appointment with Dr. Iserman. She's age 41, AMH, 0.13 FSH, 24.6 LH, 40, estrad 265, testos 12, right fallopian. I guess she wants to know if she could do IVF.
Well, it's you can't say with just a set of like blood work. I mean, it's we need an ultrasound. We need to know the whole picture, the whole story, see why the levels are like that. But certainly that just by hearing the numbers, the immediate concern is diminished ovarian reserve. So that's something that obviously Dr. Eisenman is going to have my partner is going to have to take a look very closely. And often the treatment, even with having a low AMH, which is the ovarian reserve, is not necessarily to do IVF the only route. Sometimes when the number is low, as long as there's one tube that's open, sometimes we'll try other treatments like inseminations. But this is like a long discussion, of course, and depending on what we see on the ultrasound and what the overall treatment plan is.
Yeah, we hope that answered your question. Another one. Whoops. Let's see if we can get somebody else sent in a question here. Does IVFMD waive the 6-month quarantine for a known donor or family?
What is that?
Does IVFMD, Maria, Pia, if you're on, you asked the question, does IVFMD waive the 6-month quarantine for a known donor or family?
So we follow the FDA guidelines, and in some cases that it's not that you can waive it, but in some cases tests and then we quarantine the sample. So we basically have to know what type of treatment they want to do, and then we go by FDA guidelines. So we would have to just kind of see the specifics of that case.
Got it. Good to know. All right. So I want to be respectful of your time, Dr. Soto.
No, thank
Tell
you.
our audience, yeah, my pleasure. Tell our audience before I let you go where they can find you online, especially if they want to connect and if they're local in the
Sure.
Miami area.
Yeah, of course. So my Instagram, you probably see it. Oh no, I'm at the IVFMD account, but my personal professional Instagram account is Miami Fertility Doc, and again, I'm Dr. Soto. So you're more than welcome, of course, to follow me there, and I'm always happy to answer questions. And some of my, or a lot of my followers are actually native Spanish speakers. So you'll see that some of the content is in Spanish, but we do bilingual. We always do bilingual.
Excellent.
Yeah.
Great to know. Well, this has been such an informative conversation, Dr. Soto. You gave so many valuable insights, especially for all of our audience members here during National Infertility Awareness Week. I want to thank you again for carving time out of your schedule. Pleasure to meet you at last.
Same here, and always happy to join, and I really thank you for the invitation.
My pleasure.
Yeah.
And I wish you much continued success.
Yeah,
thank you again.
Thank you. Take care. I'll see you soon.
Thank you. And thanks to our audience for those amazing questions. Take care, everyone. Have a good night.
Everyone, have a good night. Thank you. Bye-bye.
Thank you. Bye.